Welcome to Virtual Clinic. I'm Dr. Ryan Bentley. This month is National Kidney Month. I want to discuss with you some common things that are done every day and what you can do every day to save a patient's life. And as we move forward, I think it's important for us to go back and realize again that one disease may be caused by many factors, and one factor may cause many diseases. So today we're going to discuss NSAIDs, non-steroidal anti-inflammatories. NSAIDs have been associated with acute kidney injury in the general population with the progression of disease in those with chronic kidney disease. Additionally, research shows that people with chronic kidney disease, including people with moderate to severe kidney disease, are continuing to use NSAIDs at the same rate as the general population. And I think the issue lies with the fact that they are over the counter. People think that they are safe, just like a vitamin. However, they're not safe, just like a vitamin. So let's dive into the anatomy and understand a little bit more about the kidney and what's going on. So inside the kidney, we have a filtration system. And this filtration system is called the glomerulus. And the glomeruli that are inside the kidney filter the blood that comes through. So you have an afferent arteriole bringing blood in, and the blood squeezes in and out through these little capillary beds, and then it'll release extra fluid, electrolytes, hydrogen ions. There's much more detail to that, but that's beyond the point of this lecture right now. But that's going to create urine going through the tubules. And then the blood will continue through the efferent arteriole and now go to the rest of the body. So now your blood has been filtered by the kidneys. However, there are people that have damage to glomeruli, which will not allow the kidneys to function properly. For example, people with type 2 diabetes, they often have too much sugar floating around in their bloodstream, which will cause damage to the blood vessels here. And if you damage these blood vessels, it allows proteins and things to leak in. And if you notice protein in the urine, that's not a good thing. It means that there is kidney damage occurring. So what you need to do is make sure you take the pressure off these vessels and that there's not too much protein going in and damaging it. So down here, we give people that are type 2 diabetic typically what's called an ACE inhibitor. And ACE inhibitors inhibit angiotensin II. Now, angiotensin II, the main function of this is that it preferentially constricts the efferent arteriole. If you constrict this, then there's going to be increased resistance, which is going to increase pressure, which will increase the filtration. Now, imagine if you got a bunch of protein coming through here, and this is already damaged, and you're jamming this full of more and more protein, you're just going to damage those kidneys even more. So that's why people with type 2 diabetes end up going on an ACE inhibitor, is to allow this to vasodilate. If this dilates, there's less resistance, so the blood flows through more smoothly. There's not a backup of pressure, and you don't have these proteins coming in and pounding holes in through the capillary beds consistently. Now, type 2 diabetes, as I mentioned, is one of the #1 causes of kidney failure, and NSAIDs rank up there as well. So where do NSAIDs work, and why do they cause kidney damage? Well, you got to look at the afferent arteriole, which is bringing blood supply to the glomerulus itself. And if you lose blood supply, so our kidneys is made up of two different parts called the cortex and the medulla. The blood supply that comes into the kidneys, only 10% go to the medulla, 90% stay up in the cortex. So deep down, if you decrease any kind of blood supply, you can cause an acute kidney injury very quickly and start creating kidney damage. So we don't want to do that. Well, prostaglandins preferentially dilate this, increasing the blood flow going to the kidneys. Now imagine if someone is dehydrated or somebody has congestive heart failure, that their heart is not beating as much blood, then what happens is you decrease the blood flow to the kidneys, and now you can get an acute kidney injury because of that. Anything that can disrupt flow, so we need to make sure that all those things are intact. NSAIDs come up right here, and they inhibit prostaglandins. So therefore, if you inhibit something that causes dilation, what's this going to do? It's going to preferentially constrict. So people that are just taking NSAIDs on a daily basis, they're constantly constricting the blood flow through the kidneys, causing kidney damage. That is the mechanism in which NSAIDs cause acute kidney injury. So who should we screen for people with chronic kidney disease? Because people with chronic kidney disease, you do not want them taking NSAIDs because their kidneys are already damaged. So criteria are going to be people with diabetes, people with hypertension, people that are age 60 and older, and also people that have a family history of chronic kidney disease or kidney failure. You absolutely want to look at that in these people. So how do you screen for that? There's some very simple tests that you could do to screen for chronic kidney disease. One thing that we're going to talk about is the BUN, the blood urea nitrogen. The BUN reference range, depending upon which lab, is between 7 and 18. It's formed in the liver as a final product of protein catabolism. And the BUN reflects the ratio between the production and clearance of urea as it measures the nitrogen portion of urea and a gross index of glomerular function, production, and excretion of urea. Now, the rate of BUN rise is influenced by the degree of tissue necrosis, protein catabolism, and the rate of urea nitrogen excretion by the kidneys. Now, it's less sensitive than creatinine clearance, but we'll talk about that in just a moment. So things that cause the BUN to increase are things such as inadequate excretion of the kidneys due to disease or urinary dysfunction, increased liver production of urea, shock, and dehydration. Additionally, we have infections, diabetes, acute myocardial infarction, chronic gout, excessive protein intake or catabolism, or GI hemorrhage. Now, urea is removed mainly by the kidneys. However, there's a significant amount that is dumped by the liver into the intestines where it is acted upon by the gut microflora, which can cause the recirculation of nitrogen, which makes it a useful indicator of dysbiosis or anybody that may have a disrupted intestinal flora. Hypochlorhydria has also been shown to be elevated with BUN, which means that you have decreased stomach acid. When you do that, you have undigested protein that putrefies in the gut, which increases the production of ammonia, which will eventually go into the liver and then come out as urea, and then you have those nitrogen wastes that you have to deal with again. And lastly, if you have increased adrenal function or increased cortisol, whether it's endogenous or exogenous, that's going to increase the BUN due to increased protein catabolism. Things that cause the BUN to decrease are liver failure, malnutrition, celiac disease due to impaired absorption, pregnancy, and small muscle mass. So you can see people that may have a low BUN, and that's just good because they may have low muscle mass or low protein intake. Again, that's where malnutrition comes in. And liver failure is going to be an issue in it being low because the body cannot process these nitrogen wastes. Now let's move on to creatinine. Now the reference range for creatinine, typically, depending upon the lab, is between 0.5 and 1. The child, 0.3 to 0.7. Now creatinine is the byproduct of the breakdown of muscle creatinine phosphase resulting from energy metabolism, and it's used to monitor impaired normal renal function or kidney function. The production of creatinine is consistent as long as the muscle mass remains constant. Disorders of kidney function reduce the excretion of creatinine, resulting in increased blood levels. Now, there are some things to consider with regards to creatinine levels being high, besides just looking at kidney disorders, such as giantism and acromegaly. Again, they're going to have bigger muscle mass, they're going to have increased muscle metabolism going on, which is going to increase the amount of creatinine phosphate circulating around. Again, congestive heart failure is going to do that because congestive heart failure leads to decreased blood flow to the kidneys, which can cause those little glomeruli to start popping and dying off. Therefore, you lose your filtration of creatinine. Impaired renal function, which we talked about. Urinary obstruction, you can have kidney stones, a stricture, a tumor, or some other type of obstruction such as prostate cancer. That can cause constriction around the urinary tract, not allowing the urine to flow through, causing a backup into the kidneys, causing hydronephrosis, which will ultimately lead to kidney damage. We also have dehydration, shock, and rhabdomyolysis. So dehydration and shock, again, is going to be decreased perfusion to the kidneys, which can cause damage. And the rhabdomyolysis is that you're going to have increased amounts of circulating around nitrogen waste products that can damage the kidneys at high levels. And as I mentioned earlier, prostate hypertrophy when we were talking about urinary tract obstructions. Things that cause creatinine levels to be low: decreased muscle mass, small stature, severe liver disease, inadequate dietary protein, pregnancy, and bone growth. This is Kathy. Kathy is a patient of mine that is 305 pounds. She is what I consider a late pre-diabetic, metabolic syndrome, insulin resistant. She hasn't been diagnosed with type 2 diabetes yet, but her fasting insulin is in the 40s, which is a good indicator that she's at insulin resistance. So I kind of expect that she's going to have some level of kidney damage going on, and that we wouldn't want to do things such as giving her NSAIDs as part of her regimen for her aches and pains and the things that she's dealing with. So let's take a look at her blood work and let's see what it looks like at the very first report and the things that raise concern with me. If you notice right off the bat, her fasting glucose is at 106, but her hemoglobin A1C is at 5.6. Well, that's all good and dandy, right? Well, wrong, because again, you're saying, well, her hemoglobin A1C is pretty decent. Yes, but what is the body doing to compensate? You got to come down here, and if you look at her level of insulin, it's at 41.5. So you definitely know that she's got some insulin resistance, so she's probably got some level of kidney damage going on. We look here and we see her uric acid level being elevated. We can talk about that later on, but uric acid is also 50% of the body's endogenous production of antioxidants. It also could get elevated if someone's eating a lot of fructose, and it also becomes elevated when we got a lot of protein in the body and the urea and nitrogen waste start to build up into the system, and this can be precipitating into gout for someone that has a high level like that. And then here we have BUN, the blood urea nitrogen, which is starting to elevate as well. So I don't know, is this, because the other things that we talked about with her, or is this a kidney issue that's starting to creep up? We look at her serum creatinine. It's at 1.19. Reference range for LabCorp specifically is 1.7 or 0.76 to 1.27. So she's still in range, but she's on the high end of normal here. Her estimated glomerular filtration rate, she's non-African American, is at 64. Really, you want to be anything about greater than 59. So she's just ticking by here. You could be 100, you could be 120 on the GFR, and she's at 64. So I'm kind of going, we certainly got some kidney issues going on. That's what I discussed with her, helping her to determine, does she want to become healthy or not? And sure enough, she did. Now I start to see some electrolyte issues going on. So again, kidneys filter out electrolytes. So right now I'm just kind of going, okay, we got some issues, got elevated inflammatory markers, high insulin, but then I'm just a little perplexed here. I'm going, red blood cells, it's low. Well, erythropoietin is released by the kidneys due to the monitoring of blood flow. And so if the kidneys start to be damaged, you can get decreased red blood cell production. So I've got that in my head as well, going, okay, we definitely might have some issues going on with the kidneys, right? And then the last thing that I took a look at is her vitamin D production. So this month is also not only kidney, but it's also nutrition month. So let's just talk a little bit about vitamin D. So 25 vitamin D is a representation of the vitamin D that's being hydroxylized by the liver. So again, it has to go through hydroxylation in the liver in order for vitamin D to start to become active. However, the active form does not actually occur until it goes to the kidneys. And in the kidneys, it converts the 25 hydroxyvitamin D into the 125 hydroxyvitamin D. So we look here, and the normal cutoff for being low is 19.9. And you can see her level is at 24. So again, you can see the making here of poor kidney function, right? So let's take a look at her second blood work. So here we are on her second report of findings. And as you can see, I worked very hard with her with regards to her blood sugar. Hemoglobin A1C is down to 1.4. Her fasting insulin is significantly lower. It's at 26.5. She's also lost 65 pounds in this process. But we can still see that her red blood cells are decreased. So I'm like, okay, there's issues with the kidneys. That's what you should be thinking right now. We look at the vitamin D. It's at 32 and 32. So nothing to write home about, but it is up from where it was. And we did that with some nutritional supplementation, in addition to changing her diet and lifestyle. Now, because she has this high uric acid level and she was having headaches, another physician of hers decided to put her on indomethacin. And you can see very quickly what started to happen. Her potassium started to elevate. Again, potassium, anything greater than 5.2, you got to start becoming concerned because it can cause arrhythmias. 6.0 is not a good situation. So I actually sent her to the ER, and she spent 2 days in there for them to get her potassium levels down. However, if you look, by her being on indomethacin, which is a potent NSAID, non-steroidal anti-inflammatory, you can see her GFR went down from 64 down to 36. And you can see the creatinine building up, and the BUN is still building up as well. So again, we pulled her off of that, and you'll be happy to note that her creatinine level now is at 0.72, and her BUN level is back under normal levels. As you can see, this is a relatively new case. But again, you can see how the indomethacin basically cut off the blood supply to the kidneys, and it started creating damage. And when you start creating cellular death, potassium starts to leak out, which isn't a good situation. You also lose your ability to maintain normal potassium levels at the level of the kidney when you start to lose those glomeruli functioning. So again, this is something that you can see very quickly by using something that's very inexpensive. It does not cost a lot of money to run some of these tests. So let's dive right in and actually look at pricing and see how economical is this. There's a number of packages that we have inside the virtual clinic, such as the comprehensive wellness profile, that our price is $85. You can get it other places online for $97. Or you can get the basic profile for $147. And the average online retail price for this, get this, $1,036. The average retail price is $2,211 worth of blood work. So if we go with the lowest average online price, you're saving $889. Some of you are like, wow, how do you do this? Well, it's because we have over 100,000 covered lives, and we use that to get to our benefit to get the best negotiated prices for our doctors. And then also you have the Premier Profile. The Premier Profile is $357. The average retail price is over $3,500 for this blood test, and the average online is $1,267. That's a savings of $910. Or you can run some simple tests such as a urinalysis. You want to see if there's protein in the urine, which will let you know that there's kidney damage. That's $5.50 at our cost. The average online is almost $12. You're saving around $6 when you use our portal. Vitamin D, average online is $62.40. Ours is $35.65, saving you $26.75. Now, the 125 vitamin D is a very expensive test. Average is $295. Ours is about $95. You're saving almost $200 right off the bat just by using our portal. There's no membership fees or anything if you want to use the portal and order blood work. If you want all the graphs and everything that we have, yeah, we have a membership fee to take advantage of all the other things that we have in our portal. Check out the video on that down below. But you can see all the features and benefits that are part of the virtual clinic if you decide that you want to be a subscriber. If not, just start using the portal and start saving money for yourself and also your patients. I'll give you an example. Dr. Randy used our portal and ordered the blood work. He used our requisition. However, LabCorp mistakenly billed him under his own personal account as opposed to our account. And therefore, his fee was $1,821.75. So that's a lot of money for something that in our portal, it cost him $402.50. That is a huge savings. Dr. Randy says, thank you for providing the facility a virtual clinic portal. Service is a huge value. The discounts are phenomenal. So as you can see, he saved almost $1,500 just by using our portal. So something people often ask is, why would I want to do a membership? Well, again, check out the features and benefits. I'm not going to get into that, but let me just show you the profitability of being able to assess blood work with people. Each state has different rules whether or not you can upcharge blood work if patients are paying cash, you're billing insurance, different things. So we're not even factoring those things into here. Some people, they may take the blood work that's $147 and charge $395 to make a little bit of extra profit because still they're saving a ton of money. It's going to cost a patient over $2,000 to order it on their own. So they don't have any problem by passing on the savings but still making a little bit of profit at the same time. But let's put that aside. Let's just say if you do a report of findings for blood work at day 1, it's $195. You got 3 months of supplements. Right there, you're going to have $600 in supplements. And then if you look at follow-up for the ROF, that's another $195. And then you put them on a 12-week nutrition program that averages $400. So again, over these 3 months, you're doing a 12-week nutrition plan and putting this all together. So your total revenue is going to be $1,390. Your staff expense is going to be about $60. Your materials is going to be $5. Supplement cost is going to cost you $300. And that's provided that you do 100% markup on the supplements. And your total practice expenses is $365. If you take that, your profit is going to be $1,025 per patient. So how many patients can you do in 1 month? How many existing patients are in your patient base? Or how about your new patients that you have? If you do 10 cases in a month, that's $10,250 additional cash revenue into your office. 20 cases, that's an additional $20,250 extra cash, extra revenue directly into your practice. So it depends on you. What do you want to do? How do you want to help your patients? Do you want to help them save money? You want to help them be proactive? Do you want to screen for kidney disease? Do you want to help them get off their NSAIDs and show them the benefits of them by not taking the NSAIDs and what's going to happen to their body if they continue to take them by kidney failure? So I hope this video has been beneficial to you. And I want you to remember, what can be measured, can be monitored, can be managed. Someone's going to manage them. Why not it be you? Have a great day. Take care and God bless.